Hi everyone, in the next video I will explain about the pharmacological fundamentals of inhalatory anesthetics. The pharmacokinetics of inhalation anesthetic describe their absorption from the socket to the systemic circulation, its distribution in the organism, and its elimination mainly through the lungs and to a lesser extent by liver metabolism. Inhalation anesthetics are administered with the aim of achieve a concentration in the central nervous system that allows a adequate pain control in a surgical intervention. To do this, it makes the lungs reach through the ventilation system ascertain inspiratory partial pressure or P. From here, the anesthetic is captured by blood and transported to organs and tissues. After a certain saturation period, cerebral partial pressure is reached, preserved, suitable for anesthesia. Throughout the anesthesia, a gradient of partial pressures of the anesthetic so that all tissues tend to match their partial pressure with alveolar partial pressure, PA. By controlling the BP, we indirectly control the PSERP. The PA of an inhalation anesthetic is a reflection of your PSERP and is the reason why with the BP we define the speed of introduction or induction and recovery of anesthesia, and it is the measure of its power. Uh, there are different conditions to pharmacokinetics in the anesthesia machine. One of these is the physical chemical properties of anesthetics, but this part I will describe in the background. And two, the factors that determine the alveolar partial pressure. In this moment, I will explain the pharmacodynamics of inhalatory anesthetics. There are three criteria. Uh, the first is the mechanism of action. Two is CAM concept, and three is the nitrous oxide. The first is the mechanism of action. The exact mechanism by which these compounds produce the anesthetic effect is unknown, probably through direct interaction with cellular proteins, uh, causing changes in their configuration and altering neural transmission. In any case, no specific receptor is involved in this mechanism, so there is no antagonist for these drugs. It's important have in count this. And the two criteria is the CAM concept or MAC. CAM is the minimum alveolar concentration at atmospheric pressure that suppresses the motor response in 50% of individuals. In a pure inhalation anesthesia, it is necessary to reach 1.2 or 1.3 cam to prevent movement in 95% of patients. Cam decreases as age increases, and with the addition of some drugs such as opiates, clonidine, magnesium sulfate, or nitrous oxide. And the last concept or criteria is the nitrous oxide. Nitrous oxide is a gas at room temperature. The first one that was used in anesthesia in 1846. It is a poorly potent anesthetic. Its CAM is 104, which means that a total inhalation anesthetic with nitrous oxide would lead to carry it out under anoxia conditions, which is why it has been used as an adjuvant in anesthesia with allogenates in clinical practice. Uh, the different the different gases that we use in the anesthesia machine produce different effects. In this case, I will explain the effects on the nervous system, mm, effects in the respiratory system, effects in the hepatic level, and effects on renal function. In the first case, the effects on the nervous system of the anesthetics halogenated or halogenated anesthetics produce hypnosis, uh, analgesia, and anesthesia. In this involves both supra and spinal structures, but they do not have action in the peripheral nerve. Inhalation anesthetics cause decreased consumption of oxygen and cerebral flow, but not in the parallel, producing a decoupling between brain metabolism and blood flow, equally interface with self-regulations and increase intracranial pressure. The second effect is on the cardiocirculatory system. This is so important. Halogenated anesthetics lower blood pressure. Those depend of sevoflurane and desflurane. Do it by descent in the systemic vascular resistance as opposed to allothane, which produce direct myocardial depression. They also produce tachycardia, in especially deoflurane, when administered quickly. Neither sevoflurane and deflurane are arrhythmogenic, as opposed to allothane, which sensitized the myocardium to endogenous catecholamines, or they cause coronary death. On the contrary, they produce cardioprotection in surgery cardiac. The third are the effects on the respiratory system. Halogenated anesthetics in spontaneous ventilation descend of volume per minute and increase respiratory rate. They all are bronchodilators, like sevoflurane and like deoflurane, is not irritating for airway. So it is the ideal anesthetic for anesthetic induction inhalation. The four is the effects, hepatic effects. Sevoflurane as a deoflurane are safe in terms of flow and liver function. However, special mention deserves the case of the allothane since could lead to severe liver pathology by two mechanisms. The first of them due to a hypersensitivity reaction by a process autoimmune that gave rise to fulminant hepatitis. The other due to a change in the metabolism of allothane which, under hypoxic conditions or lower of air, became reduced instead of oxidative, and this fact, together with the high degree of allothane metabolisms, up to 20%, could cause uh, liver issue. And the last one are the renal function. In this case, the sevoflurane reacts with CO2 absorbers, producing the cold compound A fluoromethyl 2,2-difluoro 1 vinyl ether, which was demonstrated nephrotoxic in rats. but has never been demonstrated in humans at doses clinics. Therefore, low-flow ventilation with sevoflurane can be considered safe as far as renal function is concerned. This is all from pharmacokinetics in the anesthesia machine.
Now I'm going to talk about how the anesthesia machine works. So first of all, the anesthesia machine has four basic functions, which are the supply of oxygen, the mixing of the gases, facilitating spontaneous, control or assisted ventilation, and reducing the risk related to anesthesia to the patient and the staff. The anesthesia machine has three subsystems. The first one is gas supply, that create and provide gas mixture and patient breathing monitors. The second one is data analysis, which is hardware and software that collect and process all the information. Then the third one is physiological monitors, indicate levels and variation of physiological variables associated with cardiopulmonary function. If we continue, let me show you the parts of basic anesthesia machine. As you can see, in the front part of the anesthesia machine you have an auxiliary O2 flow meter, flow meters, vaporizers, system switch, secondary gas supply press, primary gas supply gases, a brake to hold the anesthesia machine, a flush button, carbon dioxide absorber, rebreathing bag, flow control, below assembly, and suction regulator, and a display to show you everything that it controls. Now in the back, it has electrical outlets with circuit breakers, pipeline inlets, cylinder jokes, cylinders with oxygen, nitrous oxygen and air, the main circuit breaker, oxygen power outlet, waste gas receiver, back cover, and the scavenging collector. All of them I will explain you later. Now the patient circuit. Anesthesia breathing circuit is a sterilized single-use instrument manufactured for utilization with a gas anesthesia machine. It includes pipes, one unidirectional Y and one bended L, with the gas representative collection and 3 liters rebreathing container which looks like a bag. Breathing circuits are designed for the wide audience of patients who need anesthesia from newborn, children, fully grown persons, and specialty process. A breathing system is explicative as a group of parts which joins the patient air passes to the anesthesia machine, making a fake environment. With the help of this environment, patient breathes. The anesthesia breathing circuit is manufactured to make sure that the patient will breathe in a comforting way. That is a way so as to minimize breathing labor. Well, the anesthesia machine has four basic functions, which are the supply of oxygen, the mixing of the gases, facilitating spontaneous, control or assisted ventilation, and reducing the risk related to the anesthesia to the patient and the staff. What is the gas mixture? The patient breathes a mixture of oxygen, the vapor of a volatile liquid, nitrous oxide, and other anesthetic halogenated hydrocarbon gases. They are usually extracted from the central gas supplies of the hospital. It is called fresh gas, and the pressure at is approximately 45 pounds per square inch (psi). Anesthesia machines have an oxygen supply device and an alarm that protects the patient from Inadequate oxygen supply. If the oxygen supply pressure drops below about 25 to 30 psi, the unit decreases or closes the flow of the other gases and an alarm is activated. The flow of each gas is a continuous flow unit, is controlled by a valve and is indicated by a flow meter. The flow meter can be a purely mechanical arrangement with a flow tube in which a coil moves up and down depending on the flow, or it can be an electronic sensor with an LCD screen. After the gases pass through the control valve and flow meter, enter the low pressure system, and, if is necessary, pass through a vaporizer, which are administered to the patient. The nitrous oxide and the oxygen flow controls are interconnected in such a way that the portion of oxygen in nitrous oxide can never fall below a minimal value to produce a epoxy breathing mixture. This image shows how the gases are called from the hospital gas station and are handled by the flow meters and valves. How does the vaporizer work in the anesthesia machine? Because inhalated anesthetic agents, except for nitrous oxide, exist at ambient temperature and pressure liquid at sea level, which must be evaporated by a vaporizer. Vaporizers add a controlled amount of anesthetic vapor to the gas mixture. The purpose of a vaporizer is to add anesthetic vapor into the fresh gas flow in a way that the output of the vaporizer delivers the set concentration of the anesthetic agent accurately. Fresh gas enters to the inlet of the vaporizer and is divided into two flow pathways. The splitting valve, depending on the setting of the control dial, adjusts how much goes through each of the pathway. The fresh gas that is sent along the bypass pathway doesn't come into contact with any vapor. On the other hand, the fresh gas that is sent to the vaporizing chamber becomes fully saturated with vapor. At the exit of the vaporizer, the bypass gas meets the chamber gas, and the two mix. The resultant output depends how much of fresh gas went through each of the pathways. Then it goes to the patient. In this image, it can be shown how the gases are combined with the evaporation chamber, and how from there it goes directly to the patient. What is the flush oxygen valve for? In the flow of anesthetic gases, the patient must be interrupted for any reason. An oxygen discharge valve can be activated to provide a large central oxygen flow to origin the purge the breathing circuit of anesthetic vapor. The shower flow of oxygen does not pass through the flow meters and vaporizers. What function does the scavenging system play? A sweep from the capture system and waste gas exhaust pipes to minimize the exposure of the operation room personnel to harmful anesthetic agents. Scrubber system remove gas by a vacuum and passive access system, or both. Since the amount of anesthetic gas supplies usually far exceeds the amount necessary for the patient, or pollution is decreased by scavenging. Scavenging and operating room ventilation efficiency are the two most important factors in the reduction of the waste anesthetic gases. The typical anesthesia machine absorber is a clear plastic canister or collection of canisters of varying sizes, but at least of the same volume as patient's typical tidal volume. The canister is full of some type of alkali absorbing granules. The canisters are incorporated into the ventilatory apparatus of the anesthesia machine between the expiratory and inspiratory limbs of a circle circuit. The setup is located as to be visible to anesthesia provider because visual inspection of its status and operation is very important. At expiration, the expired volume travels through an absorber canister and is exposed to the absorbent granules, where the dioxide oxide is converted to carbonic acid and then to carbonate, water, and heat. So, actually, it's a simple conversion of base to an acid. Also, the anesthesia machine has a ventilator. The automatic ventilator is generally used to mechanically deliver breath to the patient. These fans use a blow or piston instead of manually compressed reservoir bag. The ventilator forces the mixture of anesthesia gases into the breathing circuits and lungs of the patient, and in a circle breathing system receive exhale from the patient as well as fresh air.